Welcome to The Explainer. Today, we're going to build a clinical playbook for a topic that comes up a lot at the pharmacy counter: male sexual dysfunction. Our goal here is to help you turn what can be a really sensitive conversation into a huge opportunity for impactful patient care.
First things first, let's get a handle on the clinical stakes, because this is about so much more than just sex. This quote here really says it all. Vascular ED can be the canary in the coal mine for serious heart disease. It's a massive red flag, often showing up years before a heart attack or stroke.
And that's exactly where you come in. Whether a patient is just picking up a regular prescription or asking about an over-the-counter product, you're in this unique, trusted position to spot these red flags. Making this conversation a core part of your assessment, well, it can have a profound impact on their overall health. It could literally save a life. So it's absolutely crucial to have this critical triad in your head: ED, coronary artery disease, and depression. These three are so tightly linked. If a patient comes to you with one of them, you really have to be screening for the other two. The presence of one means you've got to ask about the others. No exceptions. So, how do we actually do this? Well, it all starts with knowing how to open that conversation and then asking the right questions to figure out what's really going on. Let's walk through a bit of a diagnostic framework. Let's kind of role-play this patient interview. A fantastic opening question is about the firmness of erections when they wake up. Now, why this question? Think about it. Erections during deep sleep totally bypass all the psychological stuff: anxiety, stress, you name it. So if erections are firm then, but not with a partner, it's a huge clue that you're likely dealing with a psychological or interpersonal issue, not a physical one. And to build on that, you can ask if these problems also pop up during self-stimulation. This one is a key differentiator. If a patient can get a firm erection and manage everything just fine on their own, but not with a partner, it strongly suggests the issue isn't with the plumbing. It guides you away from just thinking about meds and more towards counseling on those psychological factors. And this brings us right to the heart of the psychological side of things. Asking about their thoughts and feelings can uncover a ton: performance anxiety, distraction, stress, maybe even issues in the relationship itself. All of that mental noise can absolutely shut things down, even if the body's perfectly healthy and capable. This table right here, think of it as your roadmap. It maps the clues you get from your questions directly to potential causes. See how it works? Erections are firmer alone? Bam, think psychological. Not much sexual desire? Could be depression, low T, or hey, even their meds. Delayed ejaculation often points to a drug effect. It's a great little guide. Okay, so let's shift gears to the most common thing you're going to see, which is erectile dysfunction. Let's see how all this information builds into a practical management plan you can actually use in your practice. Management is always a two-pronged approach. Before we even think about prescriptions, it is so important to talk about the non-drug options. I mean, we have solid proof that exercise and a healthy diet really benefit patients with ED. We can't underestimate the power of these foundational changes. Now, for patients who might be considering a vacuum erection device, your counseling is absolutely critical. First, you've got to set realistic expectations. Let them know there's a learning curve. But more importantly, you have to cover the safety points. That retention band must be removed within 30 minutes. And you have to screen for contraindications like sickle cell disease or if they're on warfarin. Okay, the PDE5 inhibitors. This chart is basically your guide to picking the right one for the right person. Got a patient who wants more spontaneity? Maybe that weekend pill? Tadalafil, with its 36-hour window and no food interaction, is a great choice. But what if that same patient gets muscle pain? Okay, then sildenafil is a strong alternative. It's all about using these differences to match the drug to the patient's life. Now, when you dispense a PDE5 inhibitor, this is your single most important job. This is non-negotiable. The concurrent use of nitrates is an absolute contraindication. You have to confirm this every single time you talk to them to prevent a potentially fatal drop in blood pressure. And for some of the second-line treatments, like intracavernosal injections, the key counseling point is all about priapism. You have to be crystal clear. A painful erection that lasts for more than 4 hours is not a good thing. It is a urologic emergency. They have to get to a hospital immediately to avoid permanent damage. All right, so ED gets most of the attention, but let's broaden our focus for a minute and quickly cover the key management points for some other common dysfunctions you'll see. When it comes to premature ejaculation, you can really empower the patient by explaining behavioral techniques. The stop-start technique, for example, helps them learn to recognize and even enjoy lower levels of arousal, which gives them a lot more control. And honestly, it's often most effective when you combine it with medication. On the drug side of things, off-label SSRIs are a common choice. The important thing to counsel here is that daily dosing usually works better than just taking it on demand. Also, let them know it can take 2 or 3 weeks to really see the full benefit. And you've got to manage their expectations. When they stop the medication, the problem often comes back.
Now this is our bread and butter as pharmacists, right? I mean, look at this list. SSRIs, thiazides, spironolactone, beta blockers. We dispense these drugs all day, every day. That's why a thorough medication history is non-negotiable. A lot of the time, an existing prescription is a major factor, or maybe even the whole cause of the problem.
Okay, to finish up, let's pull all of this together into one essential checklist. These are the key points to hit in every single patient interaction you have on this topic.
This is your cheat sheet. Use it to make sure you cover all your bases. Remember that sex is biopsychosocial. Always plan a follow-up because so many so-called drug failures are actually just counseling failures. And I know I keep saying it, but reconfirm those contraindications every single time. This checklist is your key to a safe, effective, and holistic approach.
Which leaves us with one last really crucial thought. Effective management isn't just about finding the right drug. It's about recognizing how biology, psychology, and a person's social life all play together. So the question I want to leave you with is this. Beyond the prescription pad, how can you, as that trusted healthcare provider, truly address the biopsychosocial needs of your whole patient?